Good evening, everybody. Welcome to the January webinar. This evening, we've been joined by Lance Turtle. Thank you very much for joining us this evening, Lance. He's come to speak to us about where we are with COVID-19, with a particular slant, of course, on oncology. So Lance Turtle is an honorary consultant in infectious diseases up in Liverpool. And he's done a lot of research into response to vaccinations and work around COVID-19 during the pandemic and, of course, afterwards as well. And I think this is a bit of a hot topic at the moment, with particular focus on through these winter months, these respiratory viruses coming to head again. And certainly I've experienced that patients are getting concerned about it again and keen to make sure that they're up to date with their vaccinations. So I'll hand over to Dr. Lance Turtle. I'll hand over to Lance. Thank you.
So yes, as Jenny says, my name is Lance. I'm an ID physician in Liverpool. So my declaration of interest in this, I've been paid by some pharma companies for talks on this, in particular from AstraZeneca, where I participate in the Revive UK program, and actually some of the data I'm going to talk about has arisen from that program, and all that is paid to my institution. So I'm an ID physician in Liverpool. My lab works on antiviral immunity, in particular actually arthropod-borne viruses, sort of tropical diseases rather than respiratory virus infection. But I got into COVID during the pandemic, as of course many of us did. So at the moment the lab is very busy with a phase 1 Zika vaccine trial. But we've also done a lot of work, as Jenny says, on particularly T-cell responses to COVID vaccines and other viral diseases. I have been a member of the UK Health Security Agency Variant Technical Group, and I'm currently a member of the Advisory Committee on Dangerous Pathogens. I've been an investigator on quite a number of kind of large UK consortia, such as ISARIC, FOSC-COVID, and PITCH, and some of my funders are listed there. So this is a constantly evolving field, and it's hard to keep up with. And I know there's quite a lot of kind of COVID fatigue, and indeed I've experienced a lot of this myself. And actually, it sort of might surprise you to learn that actually, as a jobbing ID physician, I don't treat COVID much anymore, because we don't see it in the non-immune compromised population. The information for this talk is particularly driven by the UK NICE guidelines, but also with data from various publications and some of my own work and the work of others. And the link there, and I can circulate these slides, Jenny, if you want, or some of the links from them. The link there is this thing called Magic app, which is one way of accessing the NICE guidelines. You can also get them directly on the NICE website, but that way is meant to be a little bit more user-friendly to access. Whether or not you think that's really user-friendly, I'd be interested to know. But anyway, so I'm going to cover predominantly the things which I think are relevant for the kind of jobbing frontline clinician who deals with vulnerable patients who might be affected by COVID-19 and how you treat them. So in particular, how we stratify risk and what to do in terms of treatment. I'm not going to cover the alphabet soup of variants because it's constantly changing. Any talk is out of date within a couple of months. And if there's anything that you really need to know, it will come to you through another route anyway. Vaccination, again, there's a lot I could say about vaccination. I'd be happy to come and give another talk on that. But essentially, the take-home message is get your patients vaccinated with whatever is offered at the time. And that's, I think, all you need to know. And transmission and infection prevention and control hasn't really changed much recently, and I think that's been done to death over the last few years anyway. So the first thing to address is vulnerability. Now, there's a caveat here. So in drafting these slides, I thought, well, I've got a good idea, obviously, of what I think is a vulnerable patient, and I've worked on, some of these publications on my own, but I should look at what the actual official guidance, as if you were, a junior doctor in another specialty, a non-infection specialty, with no particular expertise. With the same expertise as everyone else, still quite considerable, not knowing nothing, but not as a special expert, and look at the kind of official list. And I found this really difficult to find, I have to say. And this was the route I had to go through to find it. So I opened up the NICE guidelines. That's the same link that was on the previous slide. In the second bullet point, you end up, if you scroll through them, you end up in the molnupiravir section first, which is not a particularly useful drug, and we'll come back to that. Molnupiravir links you to another website for who are vulnerable patients, and you click on another link and you get to a PDF. The PDF apparently has a link in it for the DHSC Independent Advisory Group report, but that link is broken. So if you then Google DHSC Independent Advisory Group report, you get two links which look extremely similar but are not. And you want the second link, the March 2023 link, where you will find another link within that, which takes you to box 1, where there's another link again to NICE Technology Appraisal TA878. And if you're still alive at that point, then you're doing pretty well. And if you're like a GP with 3 minutes to do this, or an emergency medicine physician, or an oncologist on a like a daycare unit who's trying to field dozens of phone calls about chemotherapy side effects, and in the middle of it, someone phones and says, you know, I'm on this drug, how vulnerable am I? It's basically impossible to find. The key is to Google TA878, and that will take you straight to the document, if you can remember that. If you then scroll on to section 7.2 of the NICE guidance, that does actually take you right to the same, right to the same document, actually, to the technology appraisal. I found that it's extremely obscure and very unhelpful for a jobbing frontline clinician. So if you have struggled to find this guidance, fear not. You know, you are not alone. So this is correct as of 13th of January. This link, though it was published actually in March last year. And from the perspective of an oncologist, these are the vulnerable categories, and it's what you might expect. So it's people who've got, you know, a metastatic or locally advanced cancer. Lung cancer of any stage is at particular risk. People who are receiving any kind of sort of systemic anti-cancer treatment, with the possible exception of the checkpoint inhibitors, which, as you all know, are not particularly immune suppressive. And that's within the last 12 months, so any treatment within the last 12 months. And actually also anyone who's had an operation within the last 3 months is also at increased risk. And then those who have had a resection more than 3 months ago are expected to be at less risk, but they are still at increased risk compared with the general population. So for hematological malignancies, I'm aware that you're mostly solid cancer doctors, but for hematological malignancies, the list again is well, it's most of hematological malignancies, to be honest, and the risk is, as you might imagine, higher for this group than it is for solid organ patients. So any bone marrow transplant recipient within the last 12 months, anyone who's got graft versus host disease at any point, irrespective of the timing of their transplant, that's probably the most immune suppressed group of patients that we kind of come across in adult medicine, actually. People who've had CAR T-cell therapy, I'm not sure how much that's used in solid cancer at the moment, in non-hematological malignancy. I know that in lymphoma sits in a sort of grey area between solid and liquid malignancy. And then any hematological malignancy receiving systemic anti-cancer treatment or radiotherapy in the last year, just as it is for solid tumours. And then this is a sort of mixed bag of really most of the rest of hematological disorders except MGUS. And a number of these diseases, CLL would be a good example, you know, as I'm sure you know, and some of the lymphomas as well in particular are immune suppressing from the disease itself, not only from the treatment, which I think is slightly distinct to solid organ cancer patients, where that degree of compromise is still there, but it's a bit less than it is in hematological malignancy. So I'm just going to run through some of the data that have informed this kind of risk assessment. And there are 4 studies that I've chosen to talk about: the UK CCP, which is led by Leonard Lee in Oxford, Inform, which is the AstraZeneca Revive UK kind of output that I've been involved with, Q-COVID-4, which is the work of Julia Hibbesley-Cox and colleagues in Oxford, which is a sort of a kind of large kind of general practice type data study. It's a higher level than UK CCP, which is cancer focused. Q-COVID-4 actually deals with all risk groups, not only cancer. I'm going to put out just some cancer specific data, and then some of our work within ISARIC, looking at hospitalized patients specifically. So this is Leonard Lee's paper from UK CCP, and there's a lot of data in this. And this slide is kind of, a bit too detailed to talk through in great detail, as it is. So, but if you go to the paper, then you can kind of take your time and digest this in terms of what it specifically means for the group of patients that you treat. And there's a nice breakdown of all these different solid tumor types here, where you can look at some of the differences in risk. So some interesting things to pull out. Apologies that my slides are a bit bland, so I haven't really had time to make them look very pretty. But here, if you look at the solid tumor subtype, and this is the risk of death, odds ratio of death compared with the general population without cancer, some interesting things emerge. One of them is that prostate cancer has really very little increased risk compared with the general population. The prostate cancer, of course, affects men, and some of the treatment for prostate cancer is hormonal. So you're effectively making men less male. And when you do that, and we saw this as well in ISRIC, which was never published, but when you give a man hormonal therapy to treat prostate cancer, you convert their risk to that of a woman. So you reduce the risk, by quite substantially by going from that male risk to the kind of female risk, which may well be why that prostate cancer risk is markedly lower than most of these other cancers. You'll see in here, so lung gives you quite a large increase in risk. Actually, the non-colorectal gastrointestinal tumors also have quite high risk. It's a little bit difficult to unpick this sometimes, because those are cancers that often have fairly poor outcomes anyway. Interestingly, central nervous system tumors also have quite a poor outcome, and again, they've got a poor outcome anyway. So it's difficult to know here how much of this reflects the fact that this is a group of patients who unfortunately do badly, sort of pretty much whatever the circumstances. So just a little bit on the treatment, the effective cancer treatment in this population. So there's no systemic anti-cancer therapy. So this is compared with the general population. So this is cancer patients. Let me see if I can change the pointer to the laser. There we go. So this is cancer patients not on treatment, and their risk is increased compared with the general population. If they're on treatment, any kind of treatment, the risk is substantially increased, and it's increased still more if that treatment is B or T cell depleting, so very immune suppressive. If, however, it is immunotherapy, which I think means largely checkpoint inhibition and other kind of non-immune suppressing immuno-oncology therapies, then the risk is much lower. And also hormonal therapy, the risk is much lower. Targeted therapy is a mixed bag of different things. It's a little bit difficult to interpret. So just one observation that I made of this, and I don't quite know what to make of this, but it would seem that patients with stage 4 cancer have a much higher rate of ICU admission than the general population. Now, I don't know, I'm sure that you have, as a collective group, have much more experience of this than me, but I very rarely see intensivists admit patients for ventilation and other measures who've got advanced cancer. So I'm not quite sure what's going on there. I have emailed Leonard and Tom Starkey, the authors of the paper. Tom Starkey is actually now in Liverpool. He's the first author on this paper. And there may be some issue with the data not catching up enough, and they're missing some data on those patients, and that's given rise to this kind of possibly erroneous finding. I forget the fine detail of the explanation actually, but I could circulate Tom Starkey's email if that's helpful to people. Okay, so next study. This is the INFORM study. So this is the AstraZeneca funded study. You can see the effect of a nice pharma funded study in the quality of the graphic here. So this is pharmaceutical companies in the UK have an agreement with the government whereby they can access 25% of the NHS digital data under a fee paying model. And they can then, that's anonymized data, and they can analyze that for, whatever reasons they see fit in relation to the epidemiology or outcomes of specific diseases. And so this study took a random 25% sample of the NHS digital data of the population in England, and it stratified them by whether they were immunocompromised or not, and looked at COVID outcomes according to different levels of immune suppression. So in total, I think there were about 500,000 immunocompromised people. So that would mean there's about 2 million in total in England. And then the immune competent was about the remaining about 11 million or 11.5 million. So they defined immune compromise in two different ways. So there was a broad definition, which is listed here, and this was about 4% of the total population, but it was 20% of all COVID admissions to hospital. So these patients were greatly enriched in terms of disease that was bad enough to require admission to hospital. And from the particular perspective of an oncologist, this category included patients with solid tumors within the last 5 years, nothing about treatment, just did you have cancer, yes or no, in the last 5 years, and also hematological malignancy. There was then a stringently defined immune compromised group. So whereas previously the broad group was about 4%, turning into about 20% of admission, so that's about a 5-fold enrichment. In this case, this is about a 10-fold enrichment. So you've got about 0.7% of the population, but 8% of hospital admissions. And these were more severe conditions as per the previous slide, or higher dose or more immune suppressing treatments. For transplants, either solid organ or bone marrow, they were within 2 years instead of 5 years. And for solid cancers in particular, and also hematologic cancers, is any active treatment within the last 6 months. So this is a group of people who are, clearly going to be more immune compromised, having been more recently treated. And then it also included the lymphocytic leukemia, both chronic or acute myeloid leukemia as well, and myeloma within the last 2 years. And the HIV definition was the same between the two. So this is one of the figures in the paper. There's quite a lot to unpack in this. So just to explain, on the y-axis, you see the risk of, I think it's the risk of admission to hospital. And on the x-axis, you see the population size of the group that you're talking about. So here you see solid tumors toward the bottom right, for example. So people with solid cancer is a common disease. There are lots of people in the UK who suffer from cancer, but their risk of admission to hospital with COVID is not as high as, for example, as you see up here, hematological malignancies with recent treatments, where there's a very high risk, but it's a much smaller group of people. This box is looking at just this lower left corner. So I'm just going to block out that box for a second to make it slightly clearer. So here you see the total stringently defined population and the total broadly defined population. So broadly defined population is much larger, but the risk of admission is around about double. Remember I said before there was a sort of 5-fold enrichment for this broadly defined group and a 10-fold for the stringently defined group in terms of risk of hospital admission. So here you see that reflected, that roughly doubling of risk between those two groups. But the stringently defined group is much smaller than the broadly defined group. So moving now to look at this box at the bottom left in a bit more detail. This again gives you population size on the x-axis and risk of hospital admission on the y-axis. And you can see here organ transplant, small group but quite high risk, stem cell transplant, similar, solid tumors with recent treatment, sitting roughly midway between the stringent group overall and the broadly defined group. So quite a substantial increase in risk if you've had recent treatment for cancer. So what about Q-COVID then? So Q-COVID used this chemotherapy grading system, A, B, and C, which I believe is non-standard in oncology. I have to confess, I scanned through the paper today looking for exactly what this meant and couldn't find it. So I don't know exactly what grade A and grade B and grade C chemotherapy is. And when I ask my oncology colleagues, they tell me this isn't standard. But presumably this represents a sort of increasing marrow suppression capacity of the treatment regimens. And what you can see is that as those increase, the risk increases quite substantially. But the risk of even the least immune suppressive treatment is still about 4-fold higher than the general population in terms of risk of death. And that's treatment in the last 12 months. So not necessarily someone who is actively neutropenic, but just someone who's been treated in the last year. So very substantially increased risk of death in that study, and similar risk between men and women in that study as well. So apologies for the low resolution here. This is one of my papers which is currently under review, and we're wrangling with journal editors at the moment. Hopefully this will be accepted soon. But so this is odds ratio for death, and this is hospitalized patients. This is the ISRIC CCP study, so this is only hospitalized patients, and this is looking at patients who have had recent treatment for cancer compared with patients who have no history of cancer at all. And the ISRIC study obviously was looking at a very wide range of different comorbidities and conditions and didn't collect any more granular data than that on the cancer-specific history. So we don't know the tumor type, we don't know the stage, we don't know the treatment history, etc. But what this tells you, which is interesting, is the effect of frailty and also of comorbidity on cancer patients on treatment. So when you're deciding with a patient what treatment to have and whether to have it at a time of great kind of COVID transmission, these data hopefully might help you, inform that discussion a bit. And one thing that I think is interesting that comes out of this, particularly if you look at the bottom panel, you'll see the effect in non-cancer patients here of increasing comorbidity. As comorbidity increases, the risk of death increases in non-cancer patients, and that's very well known now for COVID. But look at the effect on patients on cancer treatment. So the effect of having cancer treatment completely dominates over any effect of comorbidity, such that there was really no effect of the increase in comorbidity. Now there might be some tumor-specific differences in here. We're still, after 3 years, wrangling to try and get the National Cancer Research and Analysis Service (NCRAS) data, so we can link this with the ISRIC data and try and work out which subtypes have differential risks and what have you. But what this means in terms of deciding whether to give your patients treatment and their individual COVID risk is that actually the decision to give someone cancer treatment far outweighs any influence of their comorbidity. So if you have someone who has 1 or 2 comorbidities, that doesn't really change their risk from COVID that much compared with the risk that cancer treatment gives them. So clearly you have to weigh up the risk and benefit between what you're going to do about the cancer, which is clearly a high priority, with what would then happen if that patient catches COVID. Caveat: this database closed in February 2022, so it's largely pre-Omicron and a lot of unvaccinated patients. So this is the effect of age in the ISRIC data set. And interestingly here, effectively what you see here is that cancer adds about 20 years to your age in terms of your risk. So the non-cancer groups are all the solid lines, and the cancer groups are all the dotted lines. And there's kind of light blue and dark blue for under 50, and then red and lighter pinkish red, and green and orange and yellow. The colours roughly match. So here you will see the cancer treatment patients under 50 have approximately the same survival as those with no cancer who are 50 to 75. Shift up an age bracket, and then you see the same thing. You see the cancer treatment patients aged 50 to 69, very close to those with no cancer, aged 70 to 79, and so on and so forth. And if you look at the hazard ratios compared with patients of the same age, in the same age bracket, without cancer, although the absolute risk of death increases with advancing age, the relative risk, relative to what you would expect your risk to be if you didn't have cancer and weren't on cancer treatment in your age group, the risk is much higher in younger patients. So someone who's under 50, someone who's under 50 who gets COVID doesn't expect to die, at least not anymore. Whereas someone who's under 50 who's on cancer treatment, has a real risk of, a 5-fold increased risk at this point of death. Now, I suspect that risk has decreased since, because of vaccination and because of the amount of infection there's been. But nevertheless, the risk of younger patients, the relative risk compared with their age group, is going to be much, much higher. Set against, of course, the risk of not treating their cancer, which is your expertise and not mine. Okay, so what about treatment for people who do get COVID then, who are vulnerable? So there are 4 types of treatment available: oxygenation, antivirals, immune modulation, and antiviral antibodies. And I'm going to say a little bit about all 4 of these. So, I mean, oxygen, I mean, you know all about oxygen. You've all been junior doctors. Hypoxia is easily detected. Oxygen is life-saving, clearly. Antivirals are mostly of use in early disease, and that's to prevent progression in people who are vulnerable. COVID established kind of COVID-19 pneumonitis is an inflammatory condition which really evolves fairly late in the course of infection, and antivirals, once you've got established pneumonia and hypoxia, are of relatively limited use. Immune modulation is much more useful in those patients. In the non-immune compromised group, this kind of hyperinflammatory pneumonia that we all got used to dealing with in 2020 and 2021 as a disease syndrome has really disappeared. And we really don't see this anymore. And in my view, immune modulation in the immune competent is largely unnecessary now. We very, very rarely use it. And there is a kind of myth, I think, that steroids are treatment for COVID-19, which still circulates, which is really not correct. Steroids are treatment for hyperinflammatory pneumonia associated with COVID-19 with an oxygen requirement, not for COVID-19, per se. And then antiviral antibodies, which in principle work, but they only work if they're matched well with the virus that is infecting the person. And because viral evolution is faster than drug development, that has rendered that class of drugs really largely unuseful, with one or two exceptions. So oxygen, the current guidance is obviously to optimize other management first if you have an admitted patient. There is a conditional recommendation against high flow nasal oxygen in the NICE guidelines. I'll come back to that later. There's a conditional recommendation for proning in awake patients. I don't think we do that very often. I don't know if you guys do. And then CPAP is good. CPAP is I think, widely accessible. I don't see any reason not to use CPAP in patients with cancer. And that is particularly where you should be considering escalation for things like CPAP is in patients who are not maintaining saturations of above 94 on 40% oxygen. Of course, if you have someone who has chronic lung disease from smoking, for example, then that threshold can be a bit lower. So the evidence for this comes from the Recovery RS trial. Just to go back to the painful slide I showed you earlier on how difficult it is to find sort of up-to-date guidance in one place. When I was looking through the NICE guidance and clicking on links to go to recommendations for oxygen use, the BTS Intensive Care Society joint guidelines recommend randomization into Recovery RS. Recovery RS reported was published 2 years ago. So that gives you an idea of how out of date that guidance is, and is a sort of exemplar of the kind of COVID fatigue that we now see, and how hard it is really to stay up to date, to be honest. Recovery RS answered a very practical question: which is better to prevent intubation and death, CPAP, high flow nasal oxygen, or conventional oxygen therapy? The answer is very clear: CPAP is better. High flow and conventional oxygen are the same. And that's where the recommendation has come from, not to use high flow nasal oxygen, because apparently there's no point. Now, there's a caveat to that, in my opinion, which is that patients who, in order to be randomized into Recovery RS, you have to be suitable for ventilation. Now, notwithstanding the observation I showed you in Leonard Lee's work in the UK CCP study before, I think, and I'm sure you agree, that most cancer patients, especially those with advanced cancer, are often not considered candidates for ITU and for ventilation. And in the Recovery RS trial, only 1.9% of patients had active cancer. In our work in ISRIC, with a much more representative population, at least 3.5% of people had active cancer. So we had nearly 200,000 patients with cancer data available, and there were only two other boxes on the CRF. There was malignant neoplasm, yes, no, and there was recent treatment, yes, no. So if you take all of those with recent treatment, yes, the remainder left over with cancer data, there are about 15,000 patients. Malignant neoplasm, yes, and it's quite possible some of those had actually had recent treatment. So this 3.5% is a sort of minimum estimate. So it's at least double the number of patients in Recovery RS. So that says to me that people who were having cancer treatment were less likely to be randomized to Recovery RS, and it may be that the Recovery RS results are not quite so generalizable to your patient population as they are to the general patient population. So I would not completely rule out the usefulness of high flow nasal oxygen in your patients, especially if you have difficulties getting patients onto ITU because of this kind of perception that, it's futile, etc. I mean, we could debate whether that's right or wrong for, a long time, but I'm sure you will have your views on that. But high flow nasal oxygen is a place you can go, which could correct hypoxia while you're arguing with the intensivist about exactly what your patient's prognosis is and whether CPAP is, justified or not, etc., etc. So I leave that, as a kind of caveat on that guidance. Guidance is only guidance, and that, I think your patients sometimes don't always fit that guidance particularly well. Okay, so antiviral treatments. So there were 3 antivirals available: Paxlovid, molnupiravir, and remdesivir. Paxlovid works well, but has horrendous drug interactions. Molnupiravir basically doesn't work very well at all. And remdesivir works, but needs to be administered intravenously. So not great treatment options overall, unfortunately. Remdesivir is also very hard to get hold of. It's only got a conditional recommendation in the guidelines. It's subject to a review, the results of which I still haven't seen. And it's another COVID fatigue feature, just not keeping up with exactly where that review is. But I to do with cost effectiveness and the fact it requires admission to hospital, and therefore it's very hard to get hold of. So remdesivir is essentially out from your perspective at the moment, I think. The Paxlovid is a protease inhibitor. This is 2 drugs, one of which is very hard to say, and the other which is ritonavir. Ritonavir is an HIV drug. It's a protease inhibitor. It's one of the early protease inhibitors licensed for HIV treatment, and it is no longer used for its protease inhibition effect. But what it does do is it's a very potent cytochrome P450 enzyme inhibitor, which is why it has so many drug interactions. But it's actually given deliberately because of the drug interactions. And what it does is it boosts the levels of the drug it's co-administered with. It's a very common HIV treatment strategy. Lots of other protease inhibitors have quite short half-lives, and they're administered alongside ritonavir to boost their levels. And that's the rationale here. So it's a boosting agent rather than an antiviral agent in this context. And so this is recommended. So you have a patient who's on cancer treatment, they're vulnerable, they develop symptoms, they should get tested quickly because really they need to be on this drug within, I think, 5 days of symptom onset. They should not need supplemental oxygen. The evidence is all in early in disease. And they should have an increased risk for progression to severe COVID-19, which essentially all your patients do, as defined in, as you now know, the magic Google string TA878, which will take you past the 7 pages of pain and straight to the list you need. So here's some of the evidence. The EPIC-HR trial examined this, and there was a very large reduction in hospitalization or death, nearly 90%. So actually, this is a good drug. If your patient can take it, because of this issue with drug interactions with the ritonavir, very potent enzyme inhibitor, so we'll tend to increase levels of many other drugs. So if your patient can take this drug, this is a very good thing to get on and would be kind of considered first-line treatment in a vulnerable patient population. Molnupiravir, the molnupiravir comes from the war hammer of the Norse god of lightning, Thor. Mjolnir, I think it is, because apparently it's meant to hammer the virus, although actually it doesn't. What it does is it introduces kind of fatal mutations in the viral genome and renders it ablates its replication ability through accumulating so many mutations in the viral genome. So molnupiravir was originally trialed in the Move Out trial, which was pre-Omicron in the unvaccinated population. And in that population, there was about a 30% reduction in hospitalization or death in the molnupiravir group. So there was a benefit, there was statistically significant, but it was fairly modest. And then when that was retrialed in Panoramic, which was much larger and a bit later on in the pandemic with a predominantly vaccinated population, there was really no benefit. And you can see all this forest plot here with all the different categories. In the immune compromised group, there's just a trend to efficacy, but it's certainly not as good as Paxlovid. So Paxlovid would very much be first line, and molnupiravir is what you give when you want to feel better for giving something, and you haven't got any other options. So again, if you are going to use it, it's similar to Paxlovid. Within 5 days of symptom onset, high risk of progression, don't need oxygen, and this is really third line. I'm kind of presenting it a little bit in the wrong order, but it's for people who can't have Paxlovid or sotrovimab. The antibodies are covered in a separate section, which I'll come to. So Paxlovid first line, sotrovimab second, molnupiravir third. Remdesivir is an RNA-dependent RNA polymerase inhibitor, so a more classic kind of antiviral drug, a bit like ribavirin or other drugs that act on viral replication. And this, this works if you give it within 5 days, but you have to admit the patient for intravenous treatment. So it's not terribly practical. It is possible, though. So if you've got someone who really is at very, very high risk and they're very worried, that is an option. But you have to be able to get hold of the drug. The last time we tried to use it, we had to scratch around and we found one course buried in the back of a cabinet in ITU, I think. Okay, so immune modulation. So, we've all heard the steroid result, the kind of the really game-changing result that was pre-printed in early June 2020. The sort of first treatment that really was shown to actually reduce death in COVID-19. Just remember that is a disease that doesn't exist anymore. Okay, your patients are compromised and they might get a more inflammatory type disease than an immune competent person would get, but still the feeling I get talking to oncologists, and I do quite a lot of work with our hematologists in Liverpool and seeing some of their patients, and rip roaring 2020, early 2021 COVID-19 is rare now, and so think carefully about immune modulation, because I think often it's not necessarily needed. And back in the first wave, or at least in the second wave, I know we were giving a lot of antibiotics in the first wave, which turned out to be unnecessary. But by early 2021, if you saw someone with bilateral pneumonia, CRP 200, oxygen sats 88, 89, whatever, you would know what to do with that patient. You'd be comfortable it wasn't bacterial. They need steroids, oxygen, fluid management, etc. Now, when I see that, I think, are we missing a bacterial infection? And now I advocate antibiotics for those patients, the opposite of what I would have done during the second wave of COVID, for example. Tocilizumab, very much in the same category, really. The indications now are on steroids or not able to have steroids, and with an oxygen requirement. The CRP indications seem to have dropped. It would be legitimate, I think, to, based on what we know about how tocilizumab works, I think it would be legitimate to say, well, look, I've got this patient with a very, very high CRP, therefore I'm going to add tocilizumab because I think it's all COVID. With that caveat that, are you really sure that is all driven by COVID now in 2024, as opposed to what would have been the situation 3 years ago? And baricitinib, which is not that widely used now, I don't think. It's probably better than steroids in some ways, in the sense that the effect is a bit more targeted. This is actually, I think, the first example of a treatment that could be selected based on primary genomic mechanistic data, which came out of Kenny Bailey's lab in Edinburgh. Very, very interesting findings. I forgot what I was going to say about that now. Anyway, never mind. So my personal opinion is that these treatments were shown to work in a very different patient population to that we now have, mostly pre-vaccine, with a very sort of hyper-inflammatory disease, mostly first infections. And the situation we are now in is quite different. So think carefully about using those. But if you do feel they're necessary, then do use them. So here's an example of what I mean about people thinking steroids are, the patient's already on steroids, so that's okay, we'll just leave them on it. If you are admitted to hospital on steroids, your risk of death is increased. And there was a signal to that also in recovery in patients who did not have an oxygen requirement. So you need your immune system to function in order to fight off COVID-19. And this is risk of ventilation on the top panel, and this is risk of death in the bottom panel. And you can see here, if you're on pre-admission steroids, then your risk is really markedly increased of both. Odds ratio about 1.5. And then if you look at cancer patients here, they have the highest risk of all in this particular paper. This is one of, I haven't put the reference actually, this is one of my papers. In fact, if you Google me and PLOS Medicine, I think you'll find this data set. So there's just a bit about the mechanism of action of baricitinib. It's a JAK-STAT inhibitor. So it sort of modulates the immune response in a little bit of a less blunderbuss way than steroids do. And however, it's only been trialed as an add-on in patients with steroids because steroids were standard of care, at the time. And a trial of steroids versus baricitinib, I'm sure now will never be done because there's not enough disease to make it worthwhile, or not enough of the right type of disease. There's plenty of infection, of course. So antibodies. So there are various monoclonal antibodies which have been licensed. So Covimab is the only one that remains recommended. Ronapreve appeared on the formulary and then disappeared really miraculously quickly, unfortunately, because of viral escape. I'm not sure that was totally the right decision. I've got a slide on that in a minute. And then Evusheld is the AstraZeneca product, which is long-acting and was meant to be used in patients such as yours, who are going to be immune suppressed and vulnerable for some time, and they were meant to have a infusion of Evusheld, and that would cover them for several months or a season. The degree of viral escape from Evusheld was not as high as it was from Ronapreve, but it was never rolled out because it was certainly less efficacious, or thought to be less efficacious. This is quite a controversial decision, and you may well be familiar with the kind of Evusheld for UK campaign, which has run for years and years, but has ultimately, unfortunately, been unsuccessful. So this is an old slide. So Sotrovimab binds a conserved epitope, but I don't know how conserved it is anymore, actually, and its effectiveness has definitely decreased in the Omicron era, but it's not disappeared altogether. It's recommended in people over 12 and who weigh at least 40 kilos. And again, it's just similar to the to molnupiravir and to Paxlovid. It should be given early in people who don't need oxygen or don't need oxygen yet, as defined in the list in the magic Google link TA878. And you should give this to people who where Paxlovid is contraindicated or unsuitable for some reason. So Ronapreve was a mixture of two antibodies. I mean, this was good. It did work. It was potently neutralizing, and the trial data pre-Omicron, were really very encouraging. But now it's no longer available, unfortunately. So apologies, this is not presented very well, but this is some data from the CRIC, from David Bauer's lab in the CRIC, from Emma Wall's cohort that she's been running in London. And this illustrates, I think, possibly how some of our thinking has been wrong in terms of viral evolution and the effect of antibodies. So there has been a view that a variant emerges, it loses neutralization to a compound, say Ronapreve, and that's a one-way journey. And that virus, that lineage will never actually regain susceptibility. Here you can see an example of that not being true. So here is what you see here is Sotrovimab on the left, and then you see the two components of Ronapreve and then Ronapreve itself, and then the two components of Evusheld and then Evusheld itself. So if you focus on the first and the middle and the last columns as the actual drugs as you would give them to a patient. So there's the effect of the emergence of Omicron BA1 on Ronapreve. Absolutely no neutralization at all. However, BA2 and BA5 regain some susceptibility to neutralization, interestingly. So the decision to pull Ronapreve at that stage may not have been correct. Now, interestingly, although BA1 was the first Omicron variant to emerge in large numbers in the UK, it may not actually have been the first to evolve. And it may well be that BA2 actually evolved first, and then BA1 evolved from BA2. And the numbers are the wrong way around. Exactly where Omicron was for a long time, while Alpha and beta and delta were circulating is not clear, because Omicron actually emerged from a much earlier lineage than those other variants, which we were familiar with back in 2021 around that time. But probably BA2 evolved first, and then BA1 is an offshoot of BA2. But as you know now, this is very old, and these are continually emerging. And I don't have up-to-date data. I don't know. I don't know if the CRIC are still trying to keep up. I mean, it's difficult to keep up with the amount of work it is. And then you just publish a paper, and the moment you publish it, it's out of date again. It's a bit frustrating. Okay, so just some headline contraindications for some of these drugs. Paxlovid, the main issue is drug interactions. Sotrovimab, if you're young or small. Remdesivir, you shouldn't give to people who've got hepatic or renal dysfunction. Molnupiravir is also contraindicated in children and in no data in pregnancy. In fact, I don't think there's much data for any of these in pregnancy. Remdesivir, similarly, there's no data in pregnancy. So what to do if a patient tests positive? So the COVID medicine delivery units actually still exist. I hadn't kind of heard from them for quite a long time. So I emailed our local one in preparation for this talk, and they replied saying they're still in business and this is what we do. This is the phone number for Merseyside, because that's where I'm based, or you can email them. There will be individual arrangements in different areas around the country, or you can treat these people yourself. Paxlovid #1 if there are no interactions, Sotrovimab single dose infusion #2, Molnupiravir if you're desperate. And there's not much more you can do, which I have to confess I find slightly unsatisfactory after 4 years of the pandemic. We've got all these immune modulatory treatments which are great, and they all treat a disease which is effectively extinct, and they were developed against a virus which is extinct. You know, I share your kind of frustration in the inadequacy of treatments that we have for your patient group in particular. So there is another problem in the particularly immune compromised group that you probably don't see this so much in solid organ patients, but is persistent infection. Here we really have no idea what to do. There are some case reports. This is a review published mid last year, which gives a few, which sort of summarizes some of the case reports. And these are all the sort of numbers of patients reported treated with apparent success. It's a handful of patients, and you have no idea how many were treated and didn't, it didn't work, or it took forever, and then it went away, of its own accord or some reason. The other thing that is very clear is that cessation of immune suppression also works well here. So if you're having cycles of chemotherapy for a solid organ malignancy, then pausing those cycles should allow the patient to clear the virus. One of the things that some of my oncology colleagues and I are going to attempt to address next in Liverpool is what the effect of this is on the overall cancer patient journey. So there's quite a lot of data on mortality in cancer patients, overall, or mortality from 28 days from a positive COVID test. But I think that actually we need to drill down more into what is the outcome from cancer in these patients. If you have your cancer treatment interrupted, what is the effect of that on your overall patient journey and your outcome and your recurrence, relapse, whatever, depends on what disease you're managing, obviously. So that is still unknown at the present time. So watch this space for that. Another paper, again published around about the same time as that last one, slightly larger case series, looking at mostly hematological malignancy patients, actually, so not quite representative of your patient group. A lot of them had anti-CD20 therapies, so very, very B-cell depressed. And in this group, combination so being on 2 drugs and an antibody was better in this observational, unrandomized, small group of people. Whether that really applies to your patients, I don't know, because of course, you can see why a patient who's had CD20 and has no B cells and can't make an antibody response would have a differentially good response to an antibody compared with a patient who actually can make antibodies. And I know that the vulnerable groups obviously don't respond as well to vaccination. I mean, I've not discussed vaccination in the talk because it doesn't really affect how you manage people day to day. But there is this kind of a sense circulating sometimes that immune suppressed patients don't respond to vaccine. I mean, that is not true. They do respond, they just don't respond as well. And vaccination has doubtless saved thousands and thousands of lives in that patient group. So they work, they're just not as good as they are in the non-immune compromised population. So that's that. So combination therapy possibly better. No RCT. I would seek specialist advice, I think, if you have a patient who is persistently PCR positive. It's worth sequencing them just in case they have a very old variant. Sometimes that means that some of the older antibody treatments might work. If you were to uncover a Delta case, for example, I mean, they're probably all gone now, but certainly in 2022, early 23, we were still seeing the occasional patient who had very, very, very long duration of virus detectable, and they were still infected with Delta, in which case Ronapreve, has some more activity. So treatment summary, what's available is oxygen antivirals, immune modulation, antiviral antibodies. In a practical sense, from what you are likely to be able to access as kind of frontline cancer physicians, is face mask, high flow, and possibly CPAP, oxygen. Antivirals will be Paxlovid #1, Sotrovimab #2, Molnupiravir #3, and then immune modulation, which I think you should be thinking very carefully about if you're going to use it. And I think probably if you have someone who's, especially now we are moving into an era where you will be treating patients who've developed new cancers well after they've been vaccinated. So we've now got a very different population to where these drugs were originally trialed. And I don't know really if when someone is immune competent, they get vaccinated and they're low risk and they're totally fine and they're immune or immune to severe disease, and then a year or two down the line they get cancer and they get treatment, what their risk of severe disease is, I don't think we really know that yet. And I don't know if they're going to get the sort of hyperinflammatory pneumonia of 2020 and 2021. So if these patients present with what looks to you like COVID and they have very high CRP, etc., think of these, but also think of bacterial infection as well. I'm going against all the AMR treatment, the AMR message, which I should also be giving you. But just think carefully, individualize your treatment. I mean, this is teaching is like eggs, really. I'm sure you know how to do that anyway. Okay, so that's all I have to say. Happy to take any questions if you have them. Thank you very much.
Thank you so much, Lance, talking so clearly through the absolute wealth of data that's out there. And I think really there's certainly some take-home messages from that, some of reassurance to me, I suppose, that for the majority of our patients we treat of the solid tumour, certainly at less risk than some of that or potential high-risk groups, the hematological malignancies. I think there's still a lot of unknowns there, aren't there? I think, yes, we perhaps know what's their overall risk of death, but actually the real challenge that we often see is then going on to sort of the late effects potentially of COVID. So you get a lot of patients who talk about this long COVID that we're experiencing, and when they talk about things like that, when they run things like immunotherapy and they talk about fatigue, it's really hard to unpick what the challenges are in terms of what's the treatment that they're currently on causing in terms of symptoms, and what's related to other infections, including COVID, I suppose.
Yeah, no, and other respiratory viruses as well.
Yeah,
and I mean I think that's another question that Carlo Palmieri and I are thinking of, is the effect on the cancer patient journey overall of COVID episodes. I mean, you're right about fatigue and other viruses, but there is, we've pretty much all had COVID now, right? I mean, there is really something about COVID. The fatigue of COVID is really crippling. It's really different to anything else. I mean, I've had it twice, and each time I've had a pretty trivial illness in terms of the viral symptoms. And then I get this kind of crippling fatigue for a week afterwards. That crippling fatigue with all the other things I've had, flu and, group A strep, it's 2 or 3 days maybe. Or it might be a bit longer occasionally, but the COVID fatigue is much more disabling, even for someone who's recovered within a month completely.
Yeah,
it's really noticeable.
definitely. There's a question appeared on the chat. If you can read that, Lance, I'll just read that out.
So yes, in the ESRIC data, the effect of frailty on comorbidities compared with patients with cancer not on treatment or patients with no cancer. It is the latter. It is the patients with no cancer. So we left out the patients with the cancer box ticked who were not on treatment because we didn't know anything about when they were treated. The ESRIC CRF is not designed to look at cancer specifically. It's designed to look at loads and loads and loads and loads and loads of different things. So we only took the cancer treatment patient, and the box said, is the patient currently receiving blah 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 blah, chemotherapy, radiotherapy, stem cell therapy, etc., etc. And so that meant that we don't know, we can't differentiate the effects of cancer from the effects of cancer treatment. And we're trying to address that, in various other ways. And it may well have been the cancer. It's probably a combination of cancer and cancer treatment that's increasing the risk. And of course, the other thing we don't have in ISRIC is a group of cancer patients without COVID. And I mean, as you all know very well, cancer patients who were admitted to hospital, who often these days, if you're a cancer patient, you're picked up on screening, you come to an outpatient appointment, you're given some treatment, your journey is largely outpatient if everything goes well, apart from possibly surgery. So if you are admitted to hospital, that's often with a complication or with advanced disease or with something else. And it is not correct to assume that a cancer patient admitted to hospital has the same risk of surviving that admission as the rest of the general population, and that risk may well be higher. So that is a good point, and we can't differentiate that. That's the weakness of that study. It's quite right.
Yeah, there was a nice piece of data done by Macmillan, saying if you've got cancer and you needed admission to hospital, your risk of death was certainly higher. I think that was some data that was released last year. I think all the discussions around what antivirals we should be using, I think very much what we drum into our patients. If you have a temperature, you must call us. And I think our patients are very good at calling and saying we've got temperature. So I think we do pick those patients up early, so within those first 5 days where the treatment could be helpful. Certainly Paxlovid potentially. So I think that will be definitely helpful in reality for our patients. I think there's one more question.
Can you use Paxlovid in patients who are incidentally test positive? So that's a good question. I think the guidance is for symptomatic patients only. The problem with the asymptomatic patients, you don't know when the episode started, and they may well be coming out of it and not actually be at increased risk. So I would seek advice on that, and generally I probably wouldn't. I would stratify based on if you had a clear history of I'm on cancer treatment, I've been shielding, I went to my grandson's birthday party 3 days ago, and there were a bunch of snuffly kids, and now you're COVID PCR positive. That might lead me to treat someone if there was a clear, identifiable point of risk where you could say they might have been infected. That was within that 5 days. Of course, you would extend that 5 days by the incubation period, is about 4 to 5 days. So maybe within 9 or 10 days in that instance, then I might treat them, especially if they were at high risk, and also especially if there wasn't an adverse consequence of treating them. If it was someone who'd come into hospital with, a cancer complication of, a tumor blocking something, some important pipe or whatever, and you really need to get on and treat immediately, and you can't have Paxlovid for that reason, I might say, well, they're asymptomatic, get on and treat the cancer. That's the most life-threatening thing. I think that, or I would say that to an oncology colleague. So we'd have a discussion about that kind of risk-benefit. I think that shared decision-making is helpful, in these situations. It can be very difficult.
Yeah, absolutely. I was really interested in the data that you presented in terms of the age brackets and what a huge impact in terms of really what that means, particularly for our young patients who often we often feel a bit more laid back about potentially if they're picking up these other infections, but
Well, their risk of death is still lower than an older patient with cancer. I mean, of all your patients, who've all got cancer by definition. But I guess the point is that a young person, someone who's 45, doesn't expect to die of COVID. It's partly about expectation, and their risk is substantially higher than their age-matched non-cancer population equivalents.
Yeah.
And that's, I think, important for people to be aware of. I mean, that might be, again, because those younger patients are having more intense treatment, possibly. We don't know that in that group. Another weakness of the ISRIC data, unfortunately.
Okay. So I don't think there's any more questions come through on the chat. If there are any more questions that people want answering later, please feel free to email them in either to me or to Alison Norton, and we can always pass them on, Lance. But thank you so much for your time this evening, Lance.
And, very welcome.
Thank you very much. And just to also mention our next month webinar, 20th of February will be the next webinar, and that's on HPV cancers. And just a thank you to our sponsors, Gilead, who without their sponsorship we would struggle to put on these webinars on a monthly basis. So thank you again, Lance, and thank you to everybody for joining this evening. Okay, enjoy the rest of your evening. Thank you.
Thanks. Bye.